today. So first, let us take you to Edgar. He is a 4-year-old boy living in the Mexi locality of Fond du Blanc, Haiti. He is happy. He is happy when he's healthy. His mother, Flor, woke him up on a Monday morning and noticed the following symptoms: fever, cough with thick fluid, chest pain, and shortness of breath.
This is a case of pneumonia. Flor has a few options here. Scenario 1 is that Flor looks at her son and ultimately decides that he will be okay. Given everything else going on and the distance to the hospital, she decides not to take him to get care. He dies at home. Scenario 2 is that Flor decides to take Edgar to the hospital, but it is very far away and she must walk many hours on foot. She is also pregnant and has her 2 other children with her. This making the journey particularly difficult. Sadly, Edgar dies along the way as well. Scenario 3 is that they make it to St. Boniface Hospital, and Edgar becomes one of the 30% of patients in the hospital getting treated for respiratory infections.
What if Edgar's mother had a better option? What if Edgar's mother didn't have to travel to St. Boniface Hospital to get her son basic treatment? What if Haitians could help Haitians improve the health care in their own communities?
So a little bit of background on the St. Boniface Haiti Foundation. It is a nonprofit that is based out of Randolph, Massachusetts, and it has been established since 1983, and their primary goal is increasing the well-being and overall health for the people of Haiti, specifically within the Fond du Blanc region, which is 70 miles southwest of Port-au-Prince. Their primary pillar within Fond du Blanc is their 60-bed hospital, which in 2012 had over 45,000 patient visits alone. Other very important things is they have a very local staff, an existing network of community health workers. Last year's operating budget was very strong, over $6 million, many key partners, and their primary mission is to increase the capacity for Haitians in the local catchment area through healthcare, education, opportunities, and community development programs, and specifically utilizing respect and empowering Haitians to help others. Again, this is where Fond du Blanc is located in the country of Haiti, and it is a very rural area, and with specifically some of the issues that affect the rural population in this area is that many of them are living in poverty. Over 40% of the people in this area are living on an extreme poverty, which is classified as living less than $1 per day. There is very lack of arable land, poor infrastructure, and lack of improved water sources, which exacerbate both delay in seeking care and also some very serious health issues. Specifically, key illnesses that we will be focusing on today are malaria, acute respiratory infections, pneumonia, parasitic infections, diarrheal diseases, and malnutrition. Now that's a mouthful, but as identified by our client, we hope to address this in our scope of work. And that will be to improve the utilization of the existing community health worker network in hopes of increasing cost effectiveness. So again, this is sort of so you can see where the hospital is in relation to the various localities, and our overall goal is, again, to improve health care for the women and children in the hospital catchment area. So to do this, our primary approach will be the use of the IMCI, which is the Integrated Management of Childhood Illness approach developed by UNICEF and the World Health Organization. It is an integrated approach which will use the community health workers to address these various areas, and it has been implemented in over 75 countries around the world by the community health workers. Notable successes were in Pakistan with the lady health workers and in Bangladesh. Currently, the program is undergoing a large evaluation spanning various areas of the world, including South America. So this is an outline of our basic tasks and our plan. Again, our goal, increasing access to healthcare. And our activities, the goal is to train the community health workers to detect, treat, appropriately refer, educate, and ultimately, hopefully, to prevent the key illnesses as outlined, the key health issues right here. So first is we need to implement training. So training will begin at the top of the hospital. We will form an interdisciplinary team. The doctor, the head nurse, who is already there, community health worker manager, which we will bring into the team, and other nurses. This training team will then come together in a few training sessions to adapt the IMCI curriculum to meet the needs of both the catchment area and the Haitian population. And also not only meeting the needs of the community, but also the needs of the community health workers, as some of them have various literacy levels. The next step after that is to adapt the training and then create educational materials, which they will use in both supplemental educational trainings with the community health workers, and also they will take out with them into the community. And along that path, the community health worker manager will also be trained in this so that he or she will be able to have the same information that the community health workers will have as well. And our initial phase of training will then begin over a 3-month period. It will be weekly trainings with 20 community health workers in the first phase of the project. And they will be trained and then certified at the end of those 3 months to be able to go out into the community and do this work in their various localities. And ongoing training and support will be provided in monthly meetings, a triennial meeting which will serve as additional support, and a recertification process. And a key piece of this will also be the creation of these medical backpacks, which will serve as a toolkit for them to take out with them, and it will have toolkits for first aid, diagnostic tests, and drugs to treat the key illnesses identified. Now I'll turn it over to Jill. Thank you.
Okay, so the main tools we have in place to supervise the community health workers and monitor the program are the community health worker manager and the logbooks. So each community health worker will be required to log their daily activities when they're working within their localities. And these logbooks will be user-friendly to accommodate varying literacy levels. And the information community health workers will be required to record includes basic patient information, the symptoms seen, the diagnosis, the decided diagnosis, and the treatment or referral provided, and also the educational information on prevention methods and detection signs of that disease being discussed within the patient visit. And also the community health workers will be expected to hold at least one community health education meeting per month to educate the community members on prevention methods and detection signs of the key health issues. And they will need to log that information as well. So during the month, every month the community health workers will come to St. Boniface Hospital, as they already do, to have a monthly meeting with the community health worker manager and the head nurse. And at this time, the community health worker manager will collect the pages from the logbook from that month and use that to assess, use that information to double check that the appropriate treatments were used with each diagnosis, and also to cross-reference with the medical backpacks to make sure that the supplies were used appropriately. This will also the patients listed in the logbook will serve as information to help evaluate the overall success of the program, to see that the community health workers are increasing the patients seen over time, which would indicate that we are increasing access to health care. These meetings also provide time for the community health workers to restock their medical backpacks, and also have general time to meet with the community health manager for general supervision and support. And also provides a time for the community health workers to learn from each other. And then the triannual meetings are longer, and this is to allow time for refresher training courses to help with the recertification process every year, and also in case new protocols or procedures arise that the community health workers need to learn. And then also it would allow time to get more in-depth discussion and surveys with the community health workers to get their perspective on the program, how it's going, how their supervision is working out for them, and so on. Okay, so part of the community health workers' overall responsibilities will be that he or she will need to visit the various localities at least once every 2 months per community health worker. And the goal of these visits is to not only provide on-site supervision, but also to have conversations with community members to ensure that basically that the community health workers are doing what they said they did in the logbooks. So in regards to patient visits, diagnosis, treatment, education provided, and the monthly educational meetings. And then also during these visits, or rather to measure the education aspect of this program, we'll have a baseline survey administered to patients of community health workers and participants in the monthly meetings, and then a survey every year after to assess the members, to see if the member can list at least one prevention and 3 detection signs of the key diseases, to see if they're learning. Okay, and I'll turn it over to Adam to talk about the budget.
So, as you can see by this, well, first of all, our proposed budget is going to be $250,000 over 3 years. So, it's a pretty big budget, but a major portion of that comes from the salaries. As talked about, we're going to be including increasing the scope of work for the community health workers. We're going to be hiring a new community health worker manager. The nurses are going to be doing a lot more. The doctors are going to be doing a lot more with training. And the head nurse is going to be kind of overseeing all of this along with the community health worker manager. Therefore, it's imperative to pay them appropriately so that way we can empower them to do good work. Furthermore, the staff members need to be given adequate supplies. This is a kind of an intense process, and it's something that, you know, I'm sure maybe they don't have as much experience in, so we need to make it as easy as possible for them. Giving the community health worker manager a computer so he or she can log the data, some sort of filing system would be really helpful as well. And lastly, the community health workers themselves need all the supplies that we had talked about in the backpack. And they need the educational materials to make sure they're getting the proper, educations down. So that's the budget there. Furthermore, we are going to be budgeting for a scale up in the 3rd year. So year 1 and year 2 will be only 20 community health workers with 1 community health worker manager. Provided monitoring and evaluation over year 1 and 2 are going well, year 3 we would like to see that increase to 40 community health workers and a 2nd community health worker manager. And then after that, we'd have to reevaluate to incorporate the next 20 or furthermore a year or two down the line after that. The sustainability factor, we believe this program is very sustainable because we focus on we're trying to focus on the withstanding infrastructure within the St. Boniface Hospital by using doctors, nurses, the established supply chain that's already there. These relationships that we already have will kind of eliminate the need to bring outsiders in to the program, except for that community health manager, but he or she can even be promoted from within. Furthermore, the community health workers already have a strong relationship with their communities. They have constant communication, and this is kind of a necessary tool to connect the community members and St. Boniface. So by utilizing the community health workers, it just kind of reinforces the relationship there. And finally, by allowing community health workers to both teach prevention techniques and treat diseases early in their stages, it will drive the overall healthcare cost down by not letting diseases progress further and having to get referred to the hospital and dealing with all of that. And I believe that is that. So, bringing it back to Edgard, if this program was to be implemented, it could have a very different scenario for him. This could look something like Edgar gets treated by a community health worker in the comfort of his own home, and the community health worker who administered the visual diagnostic and antibiotic treatment also educated the mother on prevention techniques and early detection so her other children don't get sick of the same diseases in their future. And this could be a reality.
Thank you.
Thank you very much.
Thank you. Steve, I know you're a community health worker advocate, so I'll let you start.
I started last first
Oh, you
last
did?
time,
Well,
yeah.
all right. Well, we'll save you for the end then.
All right.
We'll go over to David.
So I appreciated the background on the organization that was helpful, and particularly that you mentioned that this approach is based on a proven model. That was really added credibility for me. The biggest area of that I wanted to ask you about, and I think you started to address it at the end, but I'd love to probe a little bit more on it, is about the who in this program, sort of who is doing this. And originally my question is sort of, is this existing people or new people, are sort of the old people doing new things, is it new people doing new things? And I think you answered that at the end, that it's existing people doing new things, but I'm still wondering, what are they not doing, right? So if they're doing this, is there something else that they are currently doing that doesn't need to be done? Or how is it that you just add a new set of responsibilities onto a bunch of people who I imagine are already doing a lot and kind of working at capacity? So could you address that?
Well, I'll start off. So currently the network of the community health workers in the catchment area are working less time than we project them to work. They're working 2 weeks out of the month, and they're primarily doing education in the community through groups such that we had said they are already doing groups. So our original plan had started to bring everybody in, and then we realized, okay, no, we need to do an integrated approach. We need to bring in, make sure they have the proper supervision. So that's where we would take, sort of just a third of them, train them, get them the proper supervision, allow for them to have the support out in the field, because they are learning a lot of information.
And let me clarify,
Okay.
I wasn't questioning as much about the community health workers
Okay.
as the people doing the training, the people doing the supervising, the doctors, those
Okay.
folks.
Right.
Okay.
Well, first off, we accounted for them in our budget. We decided we said we would pay them fairly well, and we kind of envisioned the kind of curriculum building portion to only last maybe 2 to 3 meetings to kind of build the curriculum, and then the training portion is going to be one night a week or one day a week. Therefore, it's not going to be a terrible amount of time, and it's only over 12 weeks, so it's 12 meetings, so it's not a terrible amount of time. Still something that we would have to look into if this program were to actually get implemented in Haiti on the ground.
I'll jump in next. Great presentation. And again, the emotional energy at the beginning and the end is I think, a very useful point. Just to take issue with the reference to this program that's been developed operating in 75 countries, that absolutely creates a sense of legitimacy. At some point I heard, and again it could be my hearing, that this program is up for a major review and evaluation. So my first instinct is, well, that's interesting. Let's find out what the evaluation says before we think it's so wonderful. So that came to my head. And I would also wonder if there are some unique things about the program's relevance to Haiti that would perhaps come from that assessment. I didn't hear the word, and I don't know why I didn't, compliance. And I'm not a public health person in training, but it feels to me like one of the huge benefits of this program is improving compliance for people who are on medication for chronic disease management. So I don't know, maybe that isn't part of what this is, but I would have thought that could have been, another powerful theme. Detect, treat, refer, and improve compliance. I guess the last sort of idea that came into my mind as I was listening, and I must have been touched by the Cameroon presentation, is technology. Logbooks feel so archaic and primitive, and with tablet prices crashing, is there a way to talk about this hospital which is serving this really terribly poor area of 40% of people living on $1 a day, and creating some kind of data management piece so that